Assalamualaikum.
Waalaikumsalam.
Okay, so how many of you? 10.
Yes.
All right, let's begin our session with Ummul Kitab Al-Fatihah. Okay, all right, so how are we going to do it? One of you prepare the case to present already, is it?
Yes, sir.
Okay, so who's going to present?
Doctor.
Yeah, siapa?
Me.
Okay, all right. Does any one of you else know about this patient, about this case? Tak tahu.
Tak tahu.
Okay. All right. Asfa, proceed.
Okay. So I need to share the slide. Can you see the slide?
Yes.
Okay. Oops. Here in the slideshow, right?
Yes. We can see clearly.
So I start now. Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. So my name is Muhammad Asfar. So I will presenting the case. So this is the chief complaint, Abdul Ali Ashraf, a 5 years old Malay boy with underlying bronchial asthma, presented with a runny nose for 4 days, cough for 2 days, and rapid breathing for 1 day prior to the admission. So 4 days prior to the admissions, he had been experienced runny nose, with characterized with a clear discharge, and also her mother said that he's having history of sick contact with friends in school, where in the school there was many students having flu-like symptoms. And 2 days prior to the admissions, her mother said that his sons are having cough, which is productive in nature, and having a whitey sputums about 1 tablespoon. However, her mother denied having abnormal cough sounds such as a barking cough or whooping cough, and also his sons never experienced any facial flushings. Then 1 day prior to the admissions, his son experienced rapid breathing, which was a noisy breathing. His mother explained it to be a high-pitched sounds and prominent during expirations. His mother also noticed that there's an intercostal and subcostal recession on the chest of his sons. And also during that episodes, his sons remained silent during the episodes. However, his son still alert and responds to the mother and not irritated or agitated, and it was associated with reduced oral intake. Normally, his son will take about 3 meals per day. Then, during this episode, his son only takes 1 meal per day. And however, due to the reduced oral intake, there was no dehydration symptoms such as sunken eye, dry lips, or reduced urine output. Otherwise, her mother denied any difficulty of swallowing, neck pain, vomiting, neck stiffness, headache, and leg swelling. No other known trigger or allergen exposed prior to this episode, such as exercising, pets, smokes, or pollen. So due to these symptoms, so his mother brought his son to KK, and in the KK, his son was nebulized 3 times, where the wheezing was improved, but the SpO2 still remained 88%. So therefore, the KK, his son was referred to HTAA for further management. So for systemic review, his son having no chest pain, autopnea, paroxysmal nocturnal dyspnea, palpitation or leg edema, no abdominal pain, heartburn, hematopoiesis, diarrhea, constipation, nausea or vomiting, no urinary hysteresis, dysuria, discharge, urgency, incontinence, oliguria, polyuria or hematuria, no change in behavior, dizziness, depression, anxiety, muscle weakness or loss of consciousness, no joint, bone or muscle pain, no jaundice, discolored urine or pale stool, no bruising, epistaxis or gum bleeding, no rash ulcer or pruritus. Okay, regarding his underlying bronchial asthma, so he was diagnosed to have bronchial asthma 6 months ago. So during that times, so his sons were presented with similar symptoms of wheezing and rapid breathing and requiring admissions. So prior to that, there were multiple episodes where he required nebulization at KK, but no hospital admission needed. So during this diagnosis, so he was prescribed with MDI fluticasone to puff BT to be taken daily, and also MDI salbutamol to puff per needed. So from diagnosis until these current admissions, no hospitalization and only required nebulization once in December at nearest KK. In the last month, he denied any daytime symptoms, nighttime symptoms, any limitation in activities or need to use a reliever. So his mother claims to adhere to medication of daily MDI fluticasone and are well educated regarding aero chamber techniques and how to clean it. So his mother also denied having eczema or his mother also denied that his son having eczema or allergic rhinitis, and he also have a strong family history of atopy. Okay, so birth history, antenatally, the mother had low HB but never required blood transfusion nor had any episode of loss of consciousness. He also denied smoking during pregnancy. So he was delivered via spontaneous vertex delivery. So during that, the birth weight was 2.67 kilograms. So his son had jaundice for a few days but don't require admission or phototherapy. So development milestones, currently he was able to play sports and skipping, able to hold the pencils and copy square and triangle, able to name birthdays and tell times, as many friends and play with them properly, dresses with accents. So his development was up to his age. Feeding history, he was breastfed exclusive for 6 months, then mixed with formula milk up to 2 years and 4 months. Started complementary feeding at 6 months and currently on adult diet 3 meals per day. Not a picky eater, and also no known food and drug allergy. Immunization completed accordingly and did not miss any vaccination, as claimed by the mother. So past medical, apart from asthma, he had no other medical illness and hospitalizations, so no past surgical history. Family history, he's a second out of 3 children of age 8 and 2 respectively. So his father is 34 years old, smoking and has underlying asthma, allergic rhinitis, and diabetes mellitus on diet control. So his father working as a lorry driver. His mother is 34 years old, working as a clerk with no known medical illness. His grandmother also has asthma. Social history, he lives in Batu 11 with his family in a single-story house with basic amenities and financially adequate. Father is smoker but claimed to smoke outside the house away from the children. No carpets, flowers, dusty toys or pets in the house, but he plays with his neighbor's cat often. So mothers clean the house with a broom instead of vacuum, but does wash the bed linen every week and does not use a dryer. Okay, that's for history. So should I proceed for the physical examination?
Yes.
Okay. So so the physical examination was done on the day 2 of admissions. So general admission, he was conscious, alert, and active. There's a granula attached on the dorsum of his right hand with no active infusion, no sputum port, sputum CNS, and MDI seen around his back. He was pink and not cyanose, and not in respiratory distress. Peripherally, there was no clubbing, no peripheral cyanotic or tremors. The capillary refill time was less than 2 seconds. No noticed eczema on the flexor, and also there's a basic scars on the left deltoids. No conjunctiva pallor, scleral jaundice, no nasal polyps, no nasal congestion, and no rhinorrhea. Hydration status was good. No central stenosis, no enlarged tonsils, and no lymph nodes palpable. Vital signs: the blood pressure was normotensive, heart rate was normal, all was normal, respiratory was normal. Weight is 14.9, between 3 to 10 centile, and height is 105 cm, between 10 to 25 centile. Head circumference is 48 centimeter, between 2nd to 50 centile. It's normal. Okay, so respiratory examinations. On inspections, there's no tracheal deviation. The chest moved with respiration symmetrically. No chest wall deformity, scars or intercostal and subcostal recession. The chest expansion was equal bilaterally. Tactile vocal parameters was equal bilaterally, and also resonance on percussion equal left and right lungs. On auscultation, there was a good entry, equal bilateral with occasional ronchi, no crepitation. So basically, this is second dose affirmation. So we expect this patient already on having a normal findings, except for occasional ronchi. So on CVS examination, it was normal. FHB was not displaced. S1, S2 was heard with no murmur. Abdominal examination, the abdomen was soft and non-tender. No hepatosplenomegaly noted. The kidney was not bloodable and bowel sound was heard. Urological examination of system was intact with no abnormalities detected. Okay, so summary. So Abdul Ari, a 5 years old Malay boy with underlying bronchial asthma, well controlled. On MDI, fluticasone 2 puff BD and emitter subdermal 2 puff when needed. Presented with coryza with clear discharge for 4 days and productive cough with whitish green sputum for 2 days duration. Otherwise, there was no fever, sore throat, rash, or chest pain. 1 day prior to the admission, presented with rapid breathing and wheezing with interglottis and subcostal recession, associated with poor oral intake but no lethargic or irritable, and can still walk. Okay. So
Wait, back. Okay.
Okay.
Let's stop there. Stop your screen sharing.
Oh, stop screen sharing. Okay. Stop share. Okay.
Okay, let's go one by one. Tell me, what do you think is the diagnosis? What are the provisional diagnosis? So from everyone, what I want is, first, what do you think is the provisional diagnosis from his as first presentation? What do you think are the provisional diagnosis? I want you to give me 5 provisional diagnosis, and then why and why not the provisional diagnosis, and then comment on his presentation. Okay, all right. Let's start from my screen, and the first one is Nur Dahlia. Yes. What do you think?
So for this patient, I think the patient has mild acute exacerbation of bronchial asthma secondary to upper respiratory tract infection.
Okay, is that all?
Okay, so the reason, so patient was in onset of asthma, and then the presentation, why it's mild in severity, because from history, I don't remember the cut point for me, but there was no signs of the patient still can crying, cough, and then there was no silent chest, so it's not indicated severe asthma. So for
So my first question is, if you think it's mild, why is the child admitted?
Why the child admitted? Because
do you need to admit child with mild asthma exacerbation?
We should observe for about at least.
Observe where?
Observe in ED.
If mild asthma exacerbation, you observe in ED.
Yes. Kalau moderate to severe, baru kita admit.
Moderate to severe baru kita admit. Okay, so you think why is this child admitted?
So it's moderate.
So the child is so you change your diagnosis because the child is admitted. Okay, fine. Okay. Give me your other provisional first. Ada ramai lagi orang kita nak tembak ni. Give me your other provisional diagnosis.
So my other provisional diagnosis. Child umur berapa tadi, Asfar?
5.
Still can be I think of pneumonia because patient presented with greenish sputum and also signs of other respiratory symptoms such as rapid breathing. However, the fever, ada fever.
No, no fever.
But there was no fever. So there is points against of pneumonia.
Okay.
Orang lain tak cakap.
Oh, okay, tak apa. Okay, fine. Let's go to the next. Oh, wait. Dahlia, give me your comment on Asfa's presentation.
So basically for history, I just want maybe I missed some point, but how about the family pedigree? How about the other siblings? Is he having other siblings?
Yes,
Yes.
this is second out of 3 siblings. So the first one is 8 years old, and the third one is 2 years old. No known
2 years old, bukan second years old. 2 years old.
Yes, okay. Sorry. Okay. So siblings doesn't have any medical illness. Only his fathers and grandmothers having asthma.
Even other atopic disease like eczema or allergic rhinitis?
No.
No.
Only his father. His father have allergic rhinitis.
Okay.
Okay, Asfar, is that information enough?
Actually, no.
Okay, tell me more. Tell us more. In terms of the family history. Okay. What else? The others. What else do you want to know from Asfar regarding family history? Alia, I'm just gonna call whatever name you put. Kalau you tak nama orang lain pun, I just say Nanti attendance pun keluar nama macam ni je kot nanti. Alia, Fitriah, Nur Afiqah, Farhana, dua, is it? And then Nadirah, Nur Aiman, Nur Afiqah. What are other information regarding family history that you want to know from Asfar? Sedoh. Okay, Asfar. What do you think you should have told us a bit more regarding family history?
Maybe regarding how the family member was diagnosed with asthma.
Yes, who diagnosed the family members? Because sometimes some people they diagnose themselves. So if you look at the asthma prediction, the API, asthma predictive index, it is a doctor diagnosed asthma. It is a doctor diagnosed allergic rhinitis. So if you diagnose them yourself, if you're not under proper follow-up, if you don't have proper diagnosis, then you need to question that a little bit. Okay, fine. So how about the father and the grandmother? Yeah, okay.
And then what is the medications currently on?
So yang tadi tu dia who diagnosed them?
Oh, I don't know.
They don't know. Okay. Are they under follow-up? Are they on any medication?
Also no information about that.
Okay, all right. Okay, any other comment? Dahlia?
But since it was acute exacerbation, for summary, should we include it as one of the points for in summary? Positive family history of asthma.
Pada cik tak faham. Macam mana?
Since it is a known case and came with acute exacerbation, for summary, should we still include the positive family history as a point?
Oh yes, because an asthmatic child, an asthmatic patient, a known case of asthma can come with, if the patient comes with respiratory, with rapid breathing or anything, it doesn't necessarily mean asthma, isn't it? They can become tachypneic, dyspneic for so many other things as well. So that's the thing. Okay, all right. Any other thing? Yeah.
Doctor, can I ask?
Yes.
In this case, we want to question about the father's smoking habits, whether it has led to exacerbation of his asthma before this.
Yes, we do need to know more about the smoking habit. Asfar only mentioned father smokes, but claim to be smoking outside the house. I think so. It's good if you can tell us whether if there is any episodes of even mild exacerbation with father smoking habit, isn't it? Father doesn't smoke in the house, but doesn't mean father didn't smoke when they are together outside the house, isn't it? Aspa, want to tell us?
I'm sorry that I didn't have the information about that.
Okay, all right. Okay, let's go next. On my screen is Alia. Provisional differential comment. Lepas Alia Fitriah, lepas tu Afika, lepas tu Farhana, lepas tu Dua, lepas tu Nadirah, Nuraiman dan Nur Afika. You follow that. Okay, Alia, proceed.
Can it be acute bronchitis, but it's rare for that age?
Itu differential, provisional.
Provisional.
Your provisional first.
My provisional is moderate exacerbation of asthma. Can you hear me?
Yes, yes, yes.
Okay. And my differential is can be acute bronchitis. Other than that is pneumonia.
Stop. Can I start with that? How should you say when you diagnose asthma exacerbation, there should be a complete diagnosis, isn't it?
Moderate acute exacerbation of asthma secondary to upper respiratory tract infection.
Secondary to?
Upper respiratory tract infection.
Okay. Is that enough? Oh, typing apa tu? Is that enough? What are other things that you need for a complete asthma diagnosis? So, okay, you've mentioned exacerbation of exacerbation. You've mentioned severity of the exacerbation. So you mentioned moderate asthma, okay, and then you've mentioned the trigger. You think the trigger is upper respiratory infection. So yes. One more thing. Asthma diagnosis. Asfa is trying to say something.
On medication.
Huh?
On medication.
Not really. You want to know the control. So always asthma, you have asthma exacerbation. You mentioned the severity of the exacerbation. You mentioned the trigger or the cause of the exacerbation, and then you need to mention as well the underlying control. So if the child is newly diagnosed, you mention control. If the child is a new diagnosed, then you mention newly diagnosed bronchial asthma. If newly diagnosed bronchial asthma pun tak cukup, you nak kena bagi tahu what is the asthma status. Maknanya dia intermittent or persistent. Persistent have mild, moderate, severe, persistent, isn't it? Kalau control ada apa? Control, partly control and fully control. Okay, fine. Alia, you wanna continue?
Continue.
Yes.
My differential.
Yang provisional tadi tak habis. So,
provisional, okay. So this is moderate acute exacerbation of bronchial asthma secondary to upper respiratory tract infection. Macam nak sebut? Control.
Okay, fine. Tak apa. My question to you is, why do you think it's moderate?
Because
okay, fine. Tak apa. Alia, think. Okay, what are your other differentials?
my other differential can be pneumonia, but had been mentioned by Dahlia previously.
Okay, alright.
Other than pneumonia, it can be acute bronchitis, but rarely at that age. Other than that,
Okay, fine. Comment on his presentation.
Actually, I want to ask, do we need to comment about the nasal polyp during the examination? I mean that, do we actually can see it?
So nasal polyp is a bit tricky to see. It's better if you have a proper scope. If not, it is quite difficult to actually see on just normal examination. So I think if you can see, then that's okay. But if not, you don't need to mention actually. Okay, all right. Anything else, Alia?
No.
Okay, let's go to Nur Afika. Provisional differential comment. Mana Afika?
Sorry, Dr. Afika yang mana?
Ada dua Afika ke?
Ada dua, Doktor.
Afika yang pakai tudung color pink ni.
Okay.
AFIE. Satu lagi Afika, you're the last. Last but not least. Okay. Proceed.
So my provisional diagnosis is acute exacerbation of moderate asthma, well controlled.
Okay, baca moderate asthma apa? Severity of the. Betul ke balik?
Acute exacerbation of.
Severity is of the exacerbation.
Moderate exacerbation.
Okay. Macam mana?
Moderate exacerbation.
Okay. Sambung. Proceed. Moderate exacerbation, okay.
Of bronchial asthma.
Okay.
Secondary to upper respiratory infection.
Okay.
Well controlled.
You think it's well controlled?
Yes.
Okay.
Is well controlled.
Okay, fine. Why do you say it's moderate?
Because there is presence of accessory muscle use and also presence of wheezing.
Kalau mild tak ada wheezing.
Tapi moderate. Kalau moderate dia loud wheezing.
Kalau moderate loud wheezing. Macam ni. Okay, fine. Okay. Differentials.
I think my differential would be moderate exacerbation of bronchial asthma, secondary to pneumonia.
Okay. Why? Why and why not?
Because of the symptom of runny nose and cough, but there is no fever or there is no fever.
Okay.
Or history of sick contact.
Okay. Next.
Next, if this patient does not have any underlying bronchial asthma, I would like to suggest multi-trigger wheeze.
Okay. Why? Why not?
Because he has multiple history of similar symptoms before.
Okay. Why you say multi-trigger?
Similar symptoms before, multiple episodes.
Yeah, so but why multi-trigger asthma? So why not episodic wheeze? Why not single trigger bronchial asthma? Okay, fine, tak apa. We'll discuss a bit later. Okay. Any other differential?
No.
Satu je, dua je differential. Okay, tak apa, fine. Okay, let's go next. On my screen, the next is Farhana. Fitriah tak belum lagi kan?
Belum lagi, doktor.
Okay, Fitriah dulu.
Okay.
Mana you boleh tukar
So,
screen ni bentuk ni? Okay, fine.
my provisional diagnosis would be a moderate exacerbation of bronchial asthma, secondary to upper respiratory infection in a well-controlled asthma patient.
Okay. Tell me why you say it's moderate.
Okay, since this patient moderate because patient had difficulty in feeding but still able to tolerate feeding, and then he also stay silent during the episode but still alert and conscious according to the mother.
What do you mean? Okay, what do you mean by staying silent?
Maybe he will be having rapid breathing during talking, so that's why he stay silent.
Okay, Asfa, what do you actually mean by staying silent though? What do you actually mean?
He did not really can talk anything.
Okay, the point why I'm asking is, what do you mean by staying silent? From where? For how long has the child been saying silent? Is he being silent because he's sick? And he sometimes even we, when we are sick, we don't want to speak as well, isn't it? Unless being asked. So is it because he's sick, or is it because he has nothing else to say to his parent, or is it because he's dyspneic and tachypneic that he can't say anything? Is it because of the severe respiratory distress that he can't speak, or why? What do you mean by staying silent?
Maybe due to the rapid breathing.
I'm not. Maybe is the problem because you clerk the patient. There shouldn't be any maybe. You should be clear. Why does the child remain silent? How long has the child been remaining silent?
But doctor, actually it is not from our clerking. It is from previous case out.
Oh, bukan orang lain ni bukan, not your case up, is it?
No. We
Bukan
only
Asfar.
got 2 days.
Bukan
2 days
Asfar.
into the trip.
Oh, I thought you use case up daripada your own case yang dulu-dulu punya. Bukan
Bukan doktor.
Okay, itu macam kalau okay, fine. So anyway, even if it's not your case, the thing is, you should never say something that you're not sure. Sorry, yeah. You should never say something that you're not sure. Maknanya, the term, the phrase remain silent doesn't actually mean much unless you're able to contextualize it. So what do you mean by remain silent? Remain silent on questioning because the patient doesn't know how to ask, how to answer, or is it remain silent because of his lethargic, or is it remain silent because he's dyspneic and tachypneic, or is it because he's breathless? Why? Or is it because he has some sore throat that is difficult for him to speak? So remain silent has so many meanings behind it. So when we clerk the patient, we need to be clear what do we mean by remain silent, because being speechless is something significant, isn't it? In the asthma exacerbation severity, dia ada kan? Apa, speak in two phrases macam tu kan, two word phrases dan sebagainya. unable to speak single word phrases. So you need to know. Okay, alright. Siapa tadi? Tak boleh, Fitri lah, tak boleh lagi kan?
Ya, tak boleh. So,
Okay. What
saya
else?
kata dia, my definition would be pneumonia. Since patient having UITI symptoms, which is runny nose, cough. However, patient does not have fever. My other definition would be a viral indismiss. Since patient could be viral infection and then causing wheezing to occur. If patient was not diagnosed with asthma before, so that could be my definition. Okay. And then another thing that I would like to ask further regarding the history, which is the asthma status of the patient. Is it mild, moderate, or severe? Is it intermittent or persistent asthma? Since I'm not sure if I missed it, the points that Asma mentioned regarding the asthma medical history about the frequency of the symptoms, so the control of the asthma. So I need to know.
Okay. Wait. Before Asma don't answer yet, let Fitria, let me ask you back.
Okay.
How do you classify asthma? You asked about intermittent, persistent, and then about control, isn't it?
Yes.
Which patient do you classify as intermittent or persistent, and which patient do you classify in terms of the control?
Okay, so in a newly diagnosed asthma before, so patient must be classified according is it intermittent or persistent asthma.
Okay.
And then for after patient having asthma, so we need to assess patient further. Is it how the control of the asthma?
Okay. So in this patient, do you think you should classify in terms of intermittent or persistent?
No. If patient was diagnosed asthma correctly before by the doctor, so we need to assess the contour of the asthma in the current presentation.
Yeah. So this type patient, especially when the child is already prescribed with corticosteroid, isn't it? Inhaled corticosteroid. The other one inhaled corticosteroid. So you should not really classify in terms of intermittent or persistent lah, isn't it? So you should classify according to the control. Okay. Have you got enough information from ASFA to actually classify the control?
No.
You think no? Okay. What information? I want you to ask specific targeted question to ASFA. What do you want to know?
Okay. Okay, I would like to ask regarding the control of asthma, which is for the past 4 weeks, is patient having any daytime symptoms, which is more than 2 times per week? Ada ke?
No, actually, it's already on the presentation, right?
Oh, saya tak perasan tu.
Asfa, you people are selective listener. No one listens to you 100%. No one. People are selective listener. We only listen to things we want to listen. So, and human beings, we always forget things. We are nasia. We always forget things. So you should never say like, oh, it's already it's okay. You can say just to cucuk sikit, but then these are listeners. Sama juga nanti bila you present in your exam, kan? Your examiners are all human beings. No examiner listens 100% to whatever you presented. So it depends on how we present.
So for this patient, actually, for the past 4 weeks, for 1 month, so there was no daytime symptoms, no nighttime symptoms, and no reliever needed, and also there's no limitation of activity. Basically, it's control.
Oh, okay. So the marks in 0, so it is a well controlled asthma.
But in 6 months, how many nebulization?
His mother says in the during the period of diagnosis until now, so there's one nebulization at KK.
Okay. So can you still say that it's well controlled?
Sorry, is it multiple episodes of nebulization or only one episode at the KK in the 6 months?
Only one.
When? The next question should be when. Is it just after the initial discharge? Or is it few weeks before this one, or when?
Wait, I see the period. Uh,
What significance does asking when give?
wait, this is on his, he was admitted at February 2020, February this year. The episode was in December.
2 months.
Okay, someone asked about why is it significant to ask when. So the thing is, you know, your lung hyperactivity sometimes. So, for example, if you are being admitted for asthma, newly diagnosed asthma, you're being discharged. So when you're discharged, the symptoms is okay. But then sometimes, you know, asthma, sometimes 1 week after the initial infection, you may get a bit more, the symptoms may get a bit more. So is it the asthma, the nebulization is part of the initial symptomology, initial illness, or is it different? We is important to know as well what type of nebulization, because you know the problem with Malaysian, especially GPs, they give nebulization for weird things as well. They don't necessarily give salbutamol nebulization. Sometimes, if you see, if they think the child has lots of coughs and things, so sometimes they give saline nebulization. Sometimes just because of secretion, they give saline nebulization and things, which is not necessarily needed most of the time. So what type of nebulization is it? Is it nebulization because of asthma exacerbation at that particular time? Or how? And then before taking nebulization, how many did the child needed frequent rescue inhaler or not? So those things. So the importance why we need to ask that question is you need to put it in context, whether is it part of the same infection or is it a different one, or is it actually an infection, or is it just what is the trigger? Okay, all right, so let's go to the next. Fitria, comment. Kau dah habis dah comment?
Yang pasal tu je lah, yang pasal asma tu je.
Okay, fine. Farhana.
You want to tell? So
Salah.
for my provisional diagnosis is moderate exacerbation of moderate acute exacerbation of bronchial asthma secondary to upper respiratory tract infection. Since the patient presented with runny nose, rapid breathing, and also with history of diagnosis of bronchial asthma 6 months ago. Sorry, I also wasn't paying attention to the control. I'm not sure. Is it was it controlled or partially controlled? I'm not sure which one was yes or no. And for my second differential, it would be acute exacerbation of bronchial asthma, secondary to viral pneumonia, and then
why viral pneumonia?
Viral pneumonia because I think he's 5 years old, right?
Okay.
So most children they get pneumonia through viruses. Yeah.
Okay, that's the same until adults lah kan. Both is virus, then only bacteria.
Okay. Okay. Other differentials.
Wait, tunggu dulu. Why viral is more in this case? Why viral is more probable rather than bacterial pneumonia?
Because the patient has runny nose. He doesn't have a fever. Usually, bacterial causes can cause.
Okay, good answer. That was what I was waiting for. Okay, all right. So bacterial has higher grade temperature usually, yes, true.
And then the patient appears more stable, since if patients if the patient gets bacterial pneumonia, most patients will deteriorate faster.
Okay. Okay, fine. Next.
Next, other differentials. Okay, I'm sorry, I'm also a selective listener. Was it was any foreign body apa? Did you
So you're thinking of foreign body inhalation.
did you exclude foreign body from your history as far?
Okay, wait. Asma, jangan jawab lagi. Let us, Farhana, what are the questions you would want him to answer for you to rule out? If you're thinking of foreign body, what are the things that you should ask him? What are the things that what are information that you would want from Asfar?
Oh, okay. I think. What information do I want? What? Rule out
For foreign body.
foreign body. Okay. What was the patient doing prior to having these symptoms? Is that okay, doctor?
Okay, apa itu tu jawapannya?
Apa dia?
Asfar, answer. You want to answer?
That is one important thing that I'm not sure.
Okay.
I do not know the.
Anything else, Farhana?
Anything else for foreign body?
Yes.
Oh, I did not exclude that in the history.
It's okay, it's not your fault.
Okay, fine. So what are the things that you would want to know? So for foreign body, one thing is what was the child doing before the onset of any of the problem? Okay, fine.
Other questions for foreign body?
Cuma. For this patient, you need to remember what was the first symptom that appears.
Runny nose, right?
Runny nose, isn't it?
Yeah,
so foreign body don't usually present with runny nose first lah kan. Okay. Okay, so cough and then apa lagi symptom dia kalau dia foreign body? Huh? Wheezing, okay. What else? Huh? Crying, okay, fine. Crying time exam pun ada crying kan, so tak apa kan.
Any other questions?
What else? Choking, sometimes dia boleh ada some symptoms of aspiration, symptoms of choking. So those things.
Wow. Hoarseness of voice, is that okay, doctor?
Yes, of course. Hoarseness of voice, change in voice. Okay, other differentials.
Okay, other differentials. All right. I'm sure the patient doesn't have any heart problems, but if
why are you so sure?
I didn't hear anything such as patient had history of congenital heart disease, because other diagnosis, if rapid breathing or whatever, it can be like heart failure, but I don't think so. I don't think I heard any history pertaining to heart causes.
Okay, he did mention some history ruling out heart failure.
Okay, sorry. Yeah.
Okay. Okay, fine. Other differential?
Other differential. All right. Other differential. I've never seen this presented so far. Yeah. But from I looked up just now, other differentials for children, I feel like I'm digging my own grave, is gastroesophageal reflux disease. This is a very low. I've never seen it before, but I Googled earlier. Seems to be a differential.
Reflux is very common. Reflux is not uncommon. Reflux is very common.
But I've never actually seen it in a child.
So GERD is a very common thing, especially sometimes in asthmatic patients. Poorly controlled asthma. One of the causes for poorly controlled asthma is poorly managed GERD. So sometimes those patients with asthma, that we have struggled in controlling, when the moment we start treatment for GERD, then symptoms get improved. Because sometimes there are micro aspirations. So these micro aspirations are causing all those frequent exacerbation. So sometimes GERD is something that you need to consider as well. Totally agree.
Straight up more about that. I'm not really familiar with those patients in pediatrics.
Okay. All right.
Right.
Okay, anything else? Okay, comment.
Comment. Comment. Good enough.
Huh?
He is good enough.
Oh, good. Why good? So good must have reason.
Okay, good must have reason. All right.
Hmm.
All right. Presentation is clear. You speak well. You seem confident. That's a good thing, right?
Yeah.
And history-wise, pertaining to the provisional diagnosis of AEBA,
Yeah.
it seems good enough. Important points are there. Just maybe the explanation we don't have enough. It's not your fault. It's okay.
Okay. All right. Okay. Next on my screen is how do I actually pronounce your name? Dua, is it?
Doa.
Dua. Oh, Dua. Okay. Okay. Fine. Okay.
Hello.
Okay. Okay. Come. Proceed.
So,
Provisional differential comment.
actually, quite similar to Farhana. He actually has my same like levels, but I'd like to add maybe some things that I think she might have missed out on the questions to ask.
No.
So
Wait.
say it. Do you want me to say it, all of it?
Yes.
Okay.
Provisional differential. Why and why not?
Okay. So my provisional diagnosis would be acute exacerbation of bronchial, mild acute exacerbation of bronchial asthma, secondary to upper respiratory tract infection that is well controlled. Because
why do you say it's mild?
Because if I'm not mistaken, Asfar mentioned that he has use of accessory muscles.
Okay, so use of accessory muscle means mild.
Well, it's in the column of mild. Either no, it's actually in moderate, but everything else is mild. So
what else? What else is mild in this patient?
He didn't seem agitated.
Did you mention about being agitated or anything?
Did you, Asfar? I don't think he mentioned it, so I'm assuming he's not agitated.
So never assume.
It's not agitated during research.
Okay, what else?
If he's not agitated, then it's mild. If he's accessory muscles, it's moderate. So take moderate instead of mild.
So you're changing your diagnosis?
Yeah, moderate.
Okay, my next question to you is, what are other information that, okay, can you just tell me from what you've listened to us far, what are other information that he has told you that may, okay, so you've mentioned agitation, you've asked about agitation, you've asked about accessory muscle. So accessory muscle, you said now usage of accessory muscle means it is in the moderate category. So what are the other things that may, how can you put the patient, whether mild, moderate, severe, life-threatening? What are the informations that Asfar has mentioned?
What Asfar has mentioned, he said that he was breathless, but he didn't say at what point is he breathless, I think, or I'm not listening to it, whether it is when he's feeding or when he's talking.
Okay.
And then we nullified that he's silent, so we don't know if he's speaking in sentences or phrases or words.
We want to know more about that. Okay, fine.
Yeah.
What else?
And he didn't seem agitated, so that felt mild.
Okay.
his respiratory rate was increased.
Are you sure it's increased? Did he say it's increased?
I'm assuming again.
Because he presented his examination at day 2, which was not tachypneic, not respiratory rate was normal at day 2. So we don't know what happened on admission,
Oh, okay.
isn't it?
Yes.
Okay, fine. Okay, so you want to know the
Second.
respiratory rate on admission? Okay, fine. What else?
And then we want to know the use of accessory muscles.
Okay, he did mention from history. Mother said intercostal and subcostal recession. Okay, my question to Asfa, I know you didn't clerk this patient, okay, but how do you know when a mother says there is intercostal and subcostal recession?
Maybe the mother will say that there's a abnormal shape of the chest, or that there's some sort of inrowing.
Okay. Anything else? Okay, my point is you should differentiate between history and physical examination. You should differentiate between symptoms and signs. It is okay for me if you say chest in drawings. If you say there's chest in drawings, I would understand. But the moment you say intercostal, subcostal recession, those are signs. Those are medical terms. Unless if the mother can say in between my ribs, they are in drawings. In between, just below the ribs, they are in drawings. So sometimes intercostal, subcostal recession are actually signs. They are not symptoms. So you need to differentiate between symptoms and signs, history and physical examination. Okay, right? So when you say mother says there's intercostal recession, oh, this must be doctor or nurse or something, isn't it? Even nurse sometimes they get confused with intercostal recession. So furthermore, mothers, so they don't. It's quite difficult. So differentiate between intercostal, between signs and symptoms. Okay, what else? Doan. How do you
Then
classify severity?
About his wheeze.
How do you classify the severity of the
His wheeze.
exacerbation? Wheeze, okay, fine.
So if it's mid wheeze or a loud wheeze,
okay,
then it's between mild and moderate.
Okay.
Then we have to check his SpO2, but I'm not sure. I wasn't listening if Asfar has mentioned his SpO2.
Yes, Asfar did mention. Asfar mentioned his SpO2 after 3 nebulization in KK. What was it? The number after 3 nebulization? You didn't mention the SpO2 before nebulization. You mentioned only after nebulization, isn't it?
Yes, after nebulization only.
So
that's why the patient is referred to HTA.
So after nebulization is 88%.
Yes.
Do you know before nebulization?
No.
Okay, after nebulization is 88%. So where can you put the patient?
Life threatening.
Sudah. So what was the admitting SpO2? Bila sampai HTA, was the child alive? Kena buat CPR ke on arrival in HTA?
Not sure.
Not sure. You think it's important?
Yes, it's important.
Yes. Okay. The point I'm trying to say here is macam ni. Yes, when you examine the patient, so you examine this patient on day 2 of admission. Asfar has mentioned clearly that when you examine the patient on day 2 of admission, the symptoms and signs may differ. The signs may differ. So your assessment of the severity at that point is not the same as the assessment of severity on admission. So that is why it is very important for us to get the condition of the patient on admission. So Asfar has mentioned about the condition of the patient according to mother punya assessment. So mother punya assessment. But as far as they mention, that assessment is when? Is it throughout the 2 days or is it just prior to admission? Was the child alert, conscious, agitated, irritable, or drowsy just prior to admission? Because if just prior to admission the child is drowsy, agitated, irritable, then it shows a different severity assessment, isn't it? Was the child silent for how long? Or is it upon arrival to HTA the child is already speechless and breathless and things? So we need to know the assessment by mother prior to admission and the assessment by the team on admission as well. So what can help you? Sometimes you won't get more information. So sometimes if, for example, if mother can say after nebulization in KK, saturation is 88%. So most likely mother will know what is the saturation on arrival, because saturation on arrival is done at triage level. It's not done at red zone, it's done at triage level. Because red zone sometimes dia halau mak keluar. Kalau baby teruk, dia halau mak keluar. Tapi at triage level, parents are there. So maknanya kalau parents boleh tahu SpO2 dekat KK, parents should know SpO2 dia dekat ED, at least at triage. So on arrival, what is the SpO2? So mother will usually know. So you can ask mother to get more information, conscious level, speech, saturation, heart rate, respiratory rate. Sometimes mother do remember. Okay, and then also you can get from the notes, but even in the exam, it's quite difficult for you to get the notes. But the point is, when you classify the severity of the exacerbation, you should assess the severity on admission, because that is how you manage. And then you can ask as well. You can ask the sorry. So you can ask the mother, what was the medication being started? Kalau on arrival, since admission, child was put on IV infusion punya medication. Apa infusion punya medication?
Corticosteroid.
IV
Infusion. Corticosteroid mana infusion?
IV salbutamol infusion.
Salbutamol infusion, magnesium sulfate. So you know these are severe, not even moderate. They are going to put in severe or life-threatening. So if the child was put on a continuous infusion, so you know this is severe. So and then you boleh ask juga about how many nebulization. So dia dapat 3 nebulization dekat KK. So dekat ED, dekat HTA, how many nebulization? Kalau bagi 1 nebulize, lepas tu admit, so you know it's not that bad. Tapi kalau bagi sampai continuous, 3 continuous nebulization dekat ED, HTA, and this is just after another 3 from KK, and you know this must be something really bad. It must be severe, at minimum would be severe. And then after admission pula, is it how much? Kalau masuk ward, 8 hourly nebulization. So you know this is not severe. 6 hourly, you know this is not severe. Tapi kalau masuk ward, first night tu dia dapat hourly nebulization. So you know this must be a severe type of asthma exacerbation. Faham? So these are history that you need to ask to actually ascertain what is the severity of the asthma exacerbation. And assessment of asthma severity, asthma exacerbation severity is very important for pediatrics, very important for internal medicine, very important for public health later on. So we have failed student because tak boleh nak ascertain whether this is mild, moderate, severe, life-threatening. So it is very important. Okay? Alright. Clear. Doa, anything else? Provisional. Differential. Let's go to differential now. You are mute. You are muted.
Sorry. My first differential will be aspiration. He's 5 years old and he's moving a lot, and there's history of playing with his friends.
Okay.
My second differential will be gastroesophageal reflux. But then I would like to ask if he had a history of vomiting after meal, and if his diet is although it's an adult, but is he taking the amount or is he eating minimally?
Okay. What else? Asfar, any info?
So the info that Doa want to know is regarding reflux disease, right?
Yes.
So there's no abdominal pain, no vomiting, no
Hiccuping after he eats?
what? Pardon?
Does he hiccup after he eats?
Oh, I do not know about that. Hiccup after eating.
There is one more thing important for assessment of GERD.
Weight gain.
Weight gain, yes, very true, exactly. So this child, the weight is at 10 to 10 to, 10 to 20 centile, is it? I can't remember.
Yeah.
It's quite low.
10 centile.
It's above 10 centile, so it's not that bad. But what is more important than just the assessment at that particular point? Weight gain lah, weight gain. So maknanya 6 months ago, last admission, was the weight the same or is it increasing or is it reducing? Has the child been gaining weight properly? 5 years old, they should still have the red book, isn't it? So the children in Malaysia, they have quite regular assessment of their weight and growth. So you can ask the mother, dia punya growth dia dekat mana? Dekat line kuning tak? And then we have a very robust program for KZM, kurang zat makanan. We have a very robust. Malaysian punya system is very good. That is why even orang asli, they can have bakul makanan, and bakul makanan they can get Pediasure. So which is very good. So is the child under KZM program? What sort of milk the child is drinking? And then obviously under any regular follow-up for kurang zat makanan or not, and all those things. Okay. All right. Comment. Doa.
My comments would be that something we all have to work on. It confuses me greatly when they refer to the boy as her and to the girl as him.
LGBT
just
punya problem. Okay, fine. Anything else?
Can I add, in this case, do we have to consider the diagnosis of cystic fibrosis?
Yes, why not? Why and why not?
Why not? Is because the age is older, like years old, and it's usually diagnosed within the first year of life.
Well, I've had newborns diagnosed with cystic fibrosis. I've had cystic fibrosis diagnosed on an unborn child yet, still an in utero diagnosis of cystic fibrosis. So you can diagnose it earlier. Not in Malaysia though. Okay, what else? Cystic fibrosis.
Why? Because he presented with the symptoms of breathlessness, wheezing, secretions.
Why not?
Why not is his age. He's kind of past, he's 5 years old, and it's usually diagnosed within the first year of life.
Okay, yes, what else?
And no family history.
No family history. Okay, what else? Because it's not common in this region. Cystic fibrosis is not common in this region. It's very, very rare in this region. So if you're working in Western country, for example, cystic fibrosis is very common. It's as common as asthma. It's even more common than asthma. So cystic fibrosis is very, very common if you're working in UK, for example. But in this region, cystic fibrosis is extremely rare. Have you seen any cystic fibrosis patient throughout your 5th year, isn't it? So you should have at least 2.5 year as medical student, clinical medical student. Have you seen any cystic fibrosis patient?
No.
No.
Some of you may have, but the thing is, it's not that many. Even in HTA, we have less than 5 patients with cystic fibrosis. The whole Malaysia, I don't think we even have 20 patients with cystic fibrosis. So we don't have that much number of patients. So yes, in terms of symptomology, cystic fibrosis may present similar, but once again, it's very uncommon in this in our region. It is more uncommon in Malay. It is more common in Chinese. And then next thing is usually cystic fibrosis they present with more frequent symptoms, more frequent problems. So for a child of 5 years old and only 2 admission, so probably it's not cystic fibrosis unless the milder type. But usually they present with more problems. Okay, alright. Let's go to the next. Kau tak habis kita. Okay, so on my screen the next one is Nur Afika. There's seorang lagi Nur Afika. Yes.
So, based on the history, my provisional diagnosis will be moderate acute exacerbation of the bronchial asthma, secondary to upper respiratory tract infection, because he was presented with upper respiratory infection symptoms such as runny nose, cough, and there was also history of sick contact in the nursery.
Okay, the child is kindergarten lah, not nursery. As far uses school pun, but it's okay.
And then my differential diagnosis.
Wait. Just to mention something. Upper respiratory tract infection. For me, it's a orang kampung punya diagnosis lah. You know why? Because there's so many structures in the upper respiratory tract tu. You have your nose, you have your throat, and throat pun ada macam-macam kat situ kan. Ada vocal cord, ada epiglottis, ada your pharynx, ada your larynx, kan. So from the thoracic inlet sampai ke atas, everything is upper respiratory tract. So there's so many structures in the upper respiratory tract tu. So okay lah, you can lah use upper respiratory infection, but the thing is, it's not entirely good enough to just say upper respiratory tract. Faham tak? Because it can be coryza, it can be pharyngitis, it can be laryngitis, it can be tracheobronchitis. Bronchitis dah already lower lah, kan? But so that's the thing. For me, sometimes if you're really stuck, then okay lah, you can use lah upper respiratory illness ni. Tapi ideally you should target which part of the upper respiratory you're trying to say. But it's okay. Okay, Afika, continue. Sorry.
But for this question, I think it is rhinitis because there is runny nose.
Okay, that's more sensible. And you need to remember as well, asthma, if you compare between asthma and also chronic lung disease, bronchopulmonary dysplasia, this type of issues, and chronic lung disease, usually the exacerbation is caused by lower respiratory tract. As compared to asthma, more commonly in asthma, the trigger is actually upper respiratory tract rather than lower respiratory tract. Okay, alright. Proceed, Afika.
So for the differential diagnosis, the first one is acute exacerbation of bronchial asthma secondary to pneumonia.
Okay.
But there was no fever. And then another differential is episodic wheeze, because the patient presented with wheeze during the viral infection, but there was no symptom other than that. There was no symptom when there was no infection.
Okay. All right.
Then another differential is cope, viral cope, because patient presented with rapid breathing and cough, but Asfar said there was no barking cough, no fever, and no hoarseness of voice.
Okay.
And then other differential is recurrent coughs due to GERD, but as Doa mentioned earlier, there was no vomiting, coughing, no increased amount in diet. And then I think Asfar tried to rule out against TB. I think
Okay.
that's all for my differential.
Okay. Comment.
So I think Asfar present quite well because it is systematic and easy to follow the history.
Okay.
Okay.
Do you have any idea how he can improve?
No.
Okay, fine. Let's go to the next. Alia. Alia, Nadirah dengan Nur Aiman ada problem connection
Alia dah tadi tak
Ya
tahu.
dah,
Ya ada dah tadi Tak ingat lah pula.
Saya belum
Tinggal Nadirah dengan Nur Aiman lah. Tiga orang.
Nadira dah.
Internet problem.
Saya tak ada kamera, tak ada, sorry.
Nur Aiman tak ada kamera.
Yeah.
You pakai phone
Desktop. I don't have a webcam.
Oh, desktop. Okay. Ingatkan pakai Nokia 3210. Okay. Nur Aiman. Okay, let's go with you.
Yes, so for my provisional diagnosis, I would like to say that it is a moderate acute exacerbation of bronchial asthma. Probably secondary to upper respiratory infection. However, I'm not sure.
Janganlah bagi probably.
Okay, secondary to upper respiratory infection.
Confident.
I'm not sure about the control assessment of the patient. Okay, and then for the provisional, because I'm among the last presenter and most of the diagnosis have already been mentioned, so I would like to give a different one. Probably I would like to give a differential, which is a vocal cord dysfunction.
Okay.
It's
okay. Why and why not?
First, because the patient has symptoms of rapid breathing, and then
why not?
Because first, he was diagnosed with bronchial asthma about previously.
Well, people do wrong diagnosis all the time.
And then because during his last admission I think the symptom recovers with bronchodilators, is it?
Okay, so there is reversal of symptoms with bronchodilator.
Yeah,
which is good. So among the reason how you diagnose asthma is by improvement after bronchodilator, isn't it? Okay, fine. Lagi, why not?
Why not?
A more important, why not? A more important negative point for vocal cord palsy, vocal cord problems.
It doesn't require trigger to occur.
Not really. If you have problem with your vocal cord, what will happen?
Hoarseness of voice.
Hoarseness of voice.
Yes. Voice punya problem lah. Ada hoarseness of voice. Ada change in the voice, for example, kan. Okay, alright. Okay, what else?
Can the patient have difficulty in feeding, Doctor? If it is vocal cord?
Vocal cord, no, unless kalau problem dia is actually swallowing in coordination. So some people, they don't have problem with sucking and things. The problem is swallowing discoordination, swallowing in coordination. So when they cannot regulate the swallowing, when it is incoordinated, sometimes they may have frequent reflux, they may have frequent aspiration, micro aspiration, and they may have problem with the vocal cord as well, because sometimes the food is acidic, something is injured to the vocal cord, those things. So can.
Oh.
Okay. All right. Anything else?
I would like to suggest tracheitis.
Tracheitis. Okay. All right.
However, the patient has no fever, because the common pathogen of bacterial tracheitis is Staphylococcus aureus, which is a bacteria. Then the patient is not that sick, I think, because bacterial tracheitis, usually the patient will be has a more toxic presentation, with high fever and symptoms that doesn't improve.
Okay. All right. Comment.
Okay, about the presentation, I'm not sure if I missed this, but as far did you mention about the compliance of the patient towards the treatment?
No, he didn't. He didn't say.
And what treatment did he get during his last?
What treatment he did give? He did say what treatment. Okay, Asfa, you wanna answer, Ivan? Okay, so is it important?
Yes.
Yes.
Yes. So compliance is important. I would put compliance on the introduction as well. So 5 years old Malay boy, known case of bronchial asthma, or newly diagnosed asthma 6 months ago, currently on medication and compliant. Currently presented with blah 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 blah. Okay. All right. Any other comment, Aiman?
No, I think that's all for me.
Okay. All right. Nadira. Nadira, okay ke tak okay?
Dia boleh okey, boleh tak okey, doktor.
Okay, cuba try. Sementara okay ni, cuba kita try. Sudah, hilang dah. Nadira, okay tak? Susah kan work from home ni kan? Okay, fine. Now, let us listen to Asfa. Asfa, what are your provisional and your differential diagnosis?
Okay, so for the provisional diagnosis, so the original provisional diagnosis that
your provisional, not the one who write the case write-up. Your provisional and your differential from your presentation.
From my perspective, so my provisional diagnosis will be life-threatening acute exacerbation of bronchial asthma, secondary to rhinitis with control asthma.
Okay, so why you put this under life-threatening?
First, because based on the history, I did not get a full history regarding to know whether this is the severity of the asthma. So based on the history that I get is after post nebulization is 88% SpO2. So I think the SpO2 is less than that before the nebulization. So it is a life-threatening.
Okay. Two things you need to remember. The first thing is sometimes SpO2 ni they depend on the element of user punya juga. So kalau you put properly, you can get different reading. And then another thing is whether the klinik kesihatan have a appropriate pediatric size punya probe. So sometimes dia pakai adapt punya probe. So adapt punya probe is quite difficult lah for you to get the proper punya ni. Sometimes dia pakai probe yang neonates punya. Neonatal probe diguna untuk pediatric age group. So if you do that, you'll get a lower SpO2 reading. So more important is actually the SpO2 on arrival to HTA. Okay. What else? So other than SpO2, what else for you to say is life-threatening?
And then regarding the episodes, so whether these patients can talk normally or not, that's I am not sure. So maybe the silent is maybe the patient cannot talk anything.
Okay.
And then regarding regarding the whiz, I did not get the whiz, the sound of the whiz during the admission to HTA. However, before that, the whiz can be heard by the mother. So maybe it progressed into a severe form. So it can be life-threatening. And then regarding the accessory muscle use, her mother noticed there's a chest indrawing. However, during admission, I did not get. And based on the info, that's all I can comment.
How did they travel from klinik kesihatan to hospital?
Yes.
How? Do you know?
No, I mean I did not know.
Okay, yes, because if it's life-threatening, do we think the klinik kesihatan will ask the parent to drive themselves to HTA?
But usually by ambulance.
Usually by ambulance, isn't it? So if the child came in with very low HPO2, they will definitely call the hospital and get proper ambulance to come. And not just that, there will be a doctor accompanying as well, isn't it? And then in between masa travel pun dia akan bagi lagi nebulization, kan? So you'll expect more. The other thing is you can ask whether they've given the hydrocortisone in the KK. Usually they will give IV medication in klinik kesihatan already. So those are the things that you can get a bit more information. Okay, fine. What are your provisional?
Provisional diagnosis.
Your differential. Sorry.
Differential will be life-threatening acute exertion of bronchial asthma secondary to pneumonia.
Okay.
And then it can be acute bronchiolitis. However, it does not fit the age of this patient.
Okay.
And then gastroesophageal reflux disease.
Okay.
And also
Okay. What else?
Cystic fibrosis. However, it is very uncommon.
Okay. All right. Okay. Let's stop. Let's okay. Before we continue, the few things that I need to mention. Okay, why if you have teachings with me, long cases, it will always be like this, like the idea. I like doing like this. If you're gonna present case, this is how you present. You present your history, you present your physical examination, you present your summary. Summary is very important. A good summary tells us that you know the diagnosis. You know about the disease, you know what's important and what is not important about your disease. You know what is the important positive and what are the important negatives for your diagnosis. So a good summary tells us that you know the problem. If you don't have good summary, however good your history is, it tells us that you don't actually know. You just hafal ni macam recorder, typist. Might as well jadi ambil typist kan. Tak payah. A good doctor should have a good clinical acumen, good clinical judgment. They will assess which part of the history and physical examination is important, and that reflects well in your summary. So good summary is very important. So you present your summary, your history, present your physical examination, present your summary. And then what I usually do is I ask the team, what do you think are the provisional, differential, and comment? Why? Because the thing is, if your team all have a good provisional diagnosis, it shows the quality of your presentation. It shows that when you present, it is very clear. People can get your provisional. If everyone have different provisional, it shows that your history is not targeted to your provisional diagnosis. It's haywire, dia pergi kelangit. And then if your friend, so again, if your friend can get at least 5 differential diagnoses from your presentation, it shows that your presentation is robust enough, covers all the possible differential. Kalau your friend nak dapat satu differential pun macam kena crack their head, fikir, sometimes they pluck from the sky saja. So it shows that your history is very too narrow. Dia tak go wide. So a good doctor should always think that someone may have wrongly diagnosed or something. So we always think about the patient. We do not think about other doctor buat apa. We always think about the patient. How can we make the patient better? So among how we do it is making sure that the diagnosis is correct. And you can never make a correct diagnosis without a good differential diagnosis. You need to have at least 5 differential diagnoses. So a good, if you have covered all those differential diagnoses, your friend can always easily, okay, first differential, second differential, third differential. And then you see juga kalau you punya friend dapat satu pun susah, it shows your presence is too narrow. Kalau your friend, everyone give at least 5 different differentials, so probably it suggests that your presentation is terlalu kelangit, terlalu pergi ke mana, it doesn't show anywhere. People just main teka macam tu saja. So having your friend suggest what are the provision and differential is actually good. It helps you and it helps them as well. Because as doctors, bila sampai introduction, chief complaint, you should already think what are the potential differential, isn't it? Baru when you know what are the differential, then can only you ask the appropriate question. Contoh ni bila you clerk patient, bolehlah you tanya, okay, datang ni apa, masalah apa, sakit apa. Tapi again, open-ended question, when you interview, when you clerk a patient, open-ended question is good, is important. But you need to remember as well, the culture here in our region, we are not forthcoming enough. Faham? You tanya, kenapa datang hospital? Sometimes the answer is, sakit kan? Tak sakit tak datang. Isn't it? So sometimes here our culture we are not forthcoming enough. So sometimes we do need to give a more targeted question. So targeted question but try to open it up a little bit. So how can you ask targeted question if you do not have your differential diagnosis? So you can only ask appropriate questions if you know the differential diagnosis. So as good doctors, the moment you hear the introduction, the moment you hear the chief complaint, you should formulate what are the differential diagnoses. The more differential diagnosis, the more questions that you're going to ask. And then you try and target, filter out what are the things. So having good diagnosis is very important. So that is why even if you listen to your friend's presentation, you need to think about the differential. Okay, so this is the reason why I always do like this. Okay, next, Asfar, tell us how would, if you are the doctor in HTA receiving this patient, so you get a call from KK. So KK nak hantar, we are sending by ambulance this patient. Okay, so tell us, how are you going to manage this patient?
So when the patients comes to the ED, to the admission, so first I would like to secure the patient come. So we need to know the condition of these patients. So we need to secure the airway, breathing, and the circulation of these patients. And then after that, airways, breathing, and circulation was stabilized and resuscitated. So we need to investigate more regarding these patients, and also need to have the history and also complete the physical examinations. Okay. So for investigation, so we can divide into bedside investigations, blood investigation, and also imaging investigations. Okay. So in bedside investigation, first we need to do we can do the peak expiratory flow rate for this patient asthma, because we want to know the bronchodilator response towards the bronchodilator response. And also we need to do bedside, we can do the ABG, actual blood gases, to know the whether this patient having respiratory distress or not, and also failure or not. So then we can classify into type 1 or type 2. Okay. So and then blood investigations, we can do the full blood counts, because one of our differential diagnosis will be pneumonia, something about infections. So if there's infection, so there's increase in white blood cells. Also we can do and another investigation we can do is the renal profile, because we know this patient having reduced oral intake, so patient might have some sort of electrolyte abnormality, such as patient having dehydrations due to reduced oral intake. So we can detect it in the renal profile. Then for imaging, so we can
Wait. Renal profile, what else you want to see? Why specifically in this patient?
in these patients, patient is on salbutamol, so patient might have
someone was trying to say something.
Hypokalemia.
Hypokalemia, yes, salbutamol.
Okay, what does salbutamol do to potassium? Anyone else? What does salbutamol do to your potassium?
Dia transport the potassium into intracellularly. So there will be less potassium in the blood.
Okay, because potassium is actually an intracellular solute. Potassium, unlike sodium, sodium is intravascular. Sodium mainly is intravascular solute. Potassium mainly is intracellular solute. But what potassium does is it shifts. What salbutamol does is it shifts potassium from intravascular into intracellular. So that is why salbutamol use dia akan jadi reduce lah. Dia menjadi hypokalemia. Alright. What else? Okay. So you mentioned RP and then you were trying to image. You were saying imaging, is it? Okay. Fine. What?
So we do the chest X-ray.
Okay.
So we expect the patient is having hyperinflated lung. Hyperinflated lung. And if this patient is having pneumonia, so we might see some sort of abnormalities, some sort of maybe opacity on the
consolidation lah. You can see
consolidation.
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 Fine.
Okay.
What else? Okay, tell me how would you manage treatment wise?
Okay, treatment wise. So for the management specifically for asthma, first we need to know the severity of this patient. So as we discussed, patient might have life-threatening severity. So for life-threatening severity, so first we need to give oxygen to these patients. So we give 1 liter per minute, and then we need to keep this patient SpO2 more than 95%, and also for life-threatening.
Wait, Asfa, you want to give 1 liter per minute oxygen by what?
1 liter pula. 8 liter. 8 liter per minute. 8 liter.
By what?
By face mask.
Face mask. Okay. Okay, fine.
And then we can give nebulized salbutamol.
Okay.
Salbutamol, and then we give IV corticosteroid.
Okay. Do you know the dose?
Corticosteroids. For salbutamol, we can give IV salbutamol continuous infusions with 1 to 5 microgram per kilogram per minute.
Okay, itu kalau salbutamol infusion, okay, fine.
Okay.
Steroid dose?
1 milligram per kilogram.
Okay, alright.
Per kilograms. And then we can give atrovert, ipratropium bromide. We give 3 times in 20 minutes intervals continuously. And we might also consider IV magnesium sulfate.
Okay.
And then after we give that, then we need to do a continuous observations to watch out for any respiratory distress. And also we need to monitor the vital signs. So we're afraid that this patient might have increase in severity.
What will you look for in the vital sign? What are the parameters that you're going to look?
The parameter is the parameter that we use to assess the severity. So we assess the respiratory rate, the pulse rates, and also the
What was the problem with pulse rate?
Because in patient with life-threatening, so usually the pulse rate, usually patient will be in the bradycardia. Okay. And then for respiratory rate.
What else? Pulse rate tadi.
Because
tachycardia after salbutamol.
Yes, tachycardia after salbutamol, after lepas tu nak bagi atrovan lagi kan. All this can cause tachycardia. Yes. Tachycardia, palpitation, arrhythmias. Okay, fine. Next. What else?
What else? That's for acute management. And of course, we need to admit this patient for continuous observation.
Okay. Okay, fine. Let's I don't have much time. Can you tell me a bit about the pathophysiology of asthma?
So asthma is basically is due to the hypersensitivity type 1. So basically it's a narrowing of the upper airway due to the allergic reaction due to the IgE mediated hypersensitivity. Okay. And then due to these activations, so there will be a releasing of all the cytokines that can cause the upper airways to be obstructed.
Okay lah. Okay. Okay, guys. I need to rush to clinic lepas ni. Macam ni. Asthma is one of the disease that you need to know in great detail. Okay, there are only few diseases that you need to know in great detail. Dengue, thalassemia, asthma. So asthma ni is a disease that you need to know in great detail. Maknanya if you get asthma, it will be very easy for you to pass, but it will be easy for you to fail as well. Maknanya kalau if you cannot answer me how you going to differentiate between the asthma severity, you don't deserve to pass if you don't know how to grade the asthma severity. So asthma is very important. It's good if you can know asthma up to the pathophysiology, because if you understand the pathophysiology, you understand how you're going to give the treatment modalities and things, why you give muscle stabilizer, why you give leukotriene inhibitor, why you give all these. If you understand the pathophysiology. So understanding the pathophysiology is very important. We have had questions before. Okay, you need to remember, yours are very different time. Masa zaman COVID ni, sampai sekarang pun kita orang tak clear lagi how the exam is going to be. The clinical exam will be difficult. So when clinical exam is going to be difficult, obviously you can already think for your time, most likely the theory exam will play an important role, isn't it? And what I can tell you is we have had questions before. We've asked about management of asthma, and of course, management of asthma, you need to be very clear. Status, how do you define status asthmaticus? How do you go into how do you manage at ED level? How you manage in kalau they go into status, how would you manage and all those things? So emergency management, you need to know that in detail. We've had questions before with a lot of mark about pathophysio of asthma as well. And we look at how the effect on the muscle, the IgE mediated and all those things. So you need to be able to explain all those things, remodeling. So you need to, there's 4 phases kan. Last stage is remodeling, lung remodeling. So you need to be able to mention all those things. Okay, all right. I'm not going to spoon feed you because you need to read. Because if I give you now, you won't remember, and some of you don't even have good internet connection. But so you need go back and read, because asthma is one case that you will get, and you'll get at least, I can assure you, blood exam is about COVID time, so we don't know what's going to happen lah. Tapi but for professional exam later on, you will definitely get asthma, because asthma is very easy. It's very easy to get patients. We have so many patients. So you need to know in great detail how about everything about the clinical management, assessment of severity, assessment of control. You need to know about the drugs. So I didn't go through about the drugs effects of where does salbutamol act, how does it act, ipratropium. Why do we give ipratropium? Why do we give magnesium sulfate? Why do you give what is the difference between fluticasone and betamethasone, for example? Fluticasone and budesonide. Why you give fluticasone rather than budesonide, for example? And then, but more important is pathophysio as well. If theory, we will definitely ask you about pathophysio. So pathophysiology of asthma, you need to know. Okay, all right. Any last few questions before we stop? My point is, I hope you guys can, nak kata go back, you already back kan, so you guys at least can after this read a bit more about asthma, because even for presenter you still need to improve your knowledge about asthma. Okay, any question, any last question before I run?
Doctor,
Yes.
may I ask, is it bronchospasm is a condition or can be used as a diagnosis? Since
Bronchospasm is a condition.
Condition. Alright, thank you.
Sama juga macam hyperactive airway disease. There is no diagnosis hyperactive airway disease. Hyperactive airway disease is not a diagnosis, but you see people writing it. So sometimes you don't have other. So ideally, you need to identify. You need to properly diagnose according to the accepted diagnostic terms. But sometimes you don't have, because some patients do have some degree of hyperactivity of the airway. Yeah. Okay, alright. But asthma, you need to be very clear if you're thinking about, and then you remember as well, asthma dia ada banyak asthma punya phenotypes. You may have single trigger bronchial asthma, you may have multi trigger bronchial asthma. You need to, you kena tahulah kenapa kita kata multi trigger. Tak bolehlah sebab multiple symptoms you kata multi trigger. So they must have multiple triggers. For all the exacerbation, dia mesti ada multiple triggers. So you need to know lah kenapa kita label dia as multi-trigger wheeze. Kenapa kita label as episodic wheeze. So you must have the reason. And when do we diagnose asthma? Usually asthma ni dia ada, we diagnose more than 3 or 5 years old baru kita diagnose asthma. We rarely diagnose asthma less than 3 years old. So all these things you need to know. Also asthma phenotype you need to know as well. Dia ada brittle asthma, dia ada something yang kita panggil brittle asthma, and then what else I can't recall. So you need to know all those things. Okay, boleh. So at least minimum reading is actually the pediatric protocol. That is the minimum reading. That is the minimum. But as pediatric protocol is just about management. It doesn't say much about the pathophysio and things. Okay, all right. Any last question?
Do we still use the API because it's currently not included in our protocol?
Yes, dia tak letak ada API tu sebabnya people sometimes depended too much on the API. But I think there are still authors suggesting that we can still rely on the API lah. Sekarang ni, I think if you go towards asthma ni, dia banyak, we are going more towards we are improving in terms of the diagnosis. Sometimes kita boleh buat nitric oxide test dan sebagainya. But I think in Malaysia we don't have that much ready yet. But I think API is still important actually. Okay, all right. Okay, I think that's all. If anything, you can just text me lah. Kalau tak nak arrange extra pun boleh, extra session pun kita boleh arrange. And then we have teaching yang semalam tak habis kan, neonatal teaching tu. Kan, nanti can you guys discuss, kita nak buat Friday
Friday je semua orang free.
Okay, alright. We'll proceed at that time. Okay, thank you. Assalamualaikum.
Salam. Thank you, Doctor.
Okay.
Thank you, Doctor.